Hello, welcome to Fade Out HIV. I'm your host, Tabitha Washington with DKB Med. Thank you for joining us for our third iteration of the Fade Out series. We started with Fade Out HIV in LA, followed it with Fade Out Diabetes in Texas, and we're so happy to focus again on HIV prevention, this time focusing on the Philadelphia area. The barbershop has been a staple for many years in the Black community. It is the hub where people can come together and discuss anything from politics to cultural events. We have used the barbershop in our programs to serve as a hub for spreading information about healthcare. This program is going to focus on using barbers in the Philadelphia area to educate their clients and the community on the importance of HIV prevention and treatment in the Black community. We are partnering with barbershops in the Philadelphia area that serve the Black community to raise this awareness. There is an opportunity for you, a clinician, to participate in this network, and we'll have more information to follow at the end of this program. Stay tuned. Our faculty for this program is Dr. Debbie Watson, Assistant Professor of Medicine with the Department of Medicine and Division of Infectious Diseases at the University of Pennsylvania's Perelman School of Medicine. Here are our faculty disclosures. This educational activity is supported by an independent educational grant from Gilead Sciences Incorporated. All activity, content, and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives. Evaluate strategies to improve HIV screening and prevention among Black men who have sex with men. Describe benefits and tenets of practicing with cultural humility. Assess eligibility and contraindications for PrEP. Identify regimens that are suitable for rapid initiation of ART. And now it's time for our pre-test. You will see the questions pop up on your screen. Please take time to answer the questions. Question 1, which of the following statements best describes the status-neutral care continuum? A, it represents the stages of HIV disease progression in an individual. B, it refers to the various prevention strategies for HIV, such as PrEP and condom use. C, it describes steps to provide comprehensive care for individuals living with HIV regardless of viral suppression status. D, it addresses HIV needs of an entire population regardless of HIV status. Question 2, which of the following features distinguishes cultural humility from cultural competency? A, critical self-reflection. B, concrete finite facts. C, working collaboratively. D, knowing everything about different cultures. Question 3, which of the following is a contraindication to PrEP? A, hepatitis B infection. B, injection drug use. C, pregnancy. D, reactive HIV tests. E, use of gender-affirming hormones. Question 4, which regimen can be offered to people with no previous use of cabotegravir PrEP who are newly diagnosed HIV before results of baseline testing are available? A, bictegravir TAF FTC. B, lamivudine dolutegravir. C, abacavir lamivudine dolutegravir. D, TAF intracidabine rilpivirine. We'll revisit these questions later on in the program. And now I'll turn it over to Dr. Watson.
Thank you, Tabitha. So to begin, let's review the current trends in HIV incidence in the United States. In 2023, the CDC estimated that 38,000 people were diagnosed with HIV in the United States. Individuals aged 25 to 34 accounted for the largest proportion of new diagnoses at 37%, followed by individuals aged 35 to 44, accounting for nearly a quarter, and youth aged 13 to 24, accounting for 18%. When we examine new HIV diagnoses by race and ethnicity, we see that non-Hispanic Black individuals account for 39% of new diagnoses, followed by Hispanic individuals at 33%. When we examine new HIV diagnoses by gender, recognizing that documentation of individuals' current gender identity is not universally performed, cisgender men accounted for 79% of new HIV infections. When we look at new diagnoses by reported mode of transmission, roughly 2/3 occur in the setting of sexual transmission between men, 1/4 in the setting of heterosexual sexual transmission, and less than 10% in the setting of injection drug use, with or without sexual contact. Nationally, Black cisgender men and Hispanic cisgender men accounted for the largest proportion of new HIV diagnoses in 2023, followed by white cisgender men. Locally in Philadelphia, 435 people were diagnosed with HIV in 2022, with Black men accounting for 45% of diagnoses. Overall, HIV incidence in the state of Pennsylvania is represented by this red bar at 8 people per 100,000 residents. However, in Philadelphia County, we see that the incidence rate is much higher at 27 people per 100,000. And in the bottom bar, we see Black people in the city of Philadelphia with a rate of 37 per 100,000, markedly higher than the national rate. The HIV care continuum is an important framework for conceptualizing and monitoring HIV medical care outcomes. The continuum consists of the following stages: knowledge of one's HIV status, linkage to HIV medical care, receipt of HIV medical care, and viral suppression, which the CDC defines as a viral load less than 200 copies per milliliter. The graph displays each of these measures at the national level, represented in blue, in Philadelphia County, represented in red, and among Black men nationally, represented in gray. Viral suppression is a key metric for defining successful engagement in HIV medical care, because for each 1% increase in viral suppression within a community, HIV incidence within that community decreases by up to 6%. HIV transmission occurs in a variety of contexts. The highest proportion are attributed to individuals who have been diagnosed and are aware of their HIV status, but are not engaged in care at 43%, followed by individuals who are living with HIV, but have not been formally diagnosed, representing 38%. There's significant variation in national HIV incidence rates. Again, Black individuals are disproportionately affected by HIV and are 8 times more likely than white individuals to be diagnosed with HIV in their lifetime. Social and structural issues such as HIV-related stigma, discrimination, poverty, and limited access to healthcare drive these deeply entrenched inequities. For example, among cisgender men who have sex with men, Black and Hispanic men have a much higher risk of acquiring HIV over their lifetime compared to Asian and white men. Now let's discuss HIV testing. Current CDC guidelines for HIV testing recommend that all individuals aged 13 to 64 be screened for HIV at least once in their lifetime. Individuals should also be screened if they're starting treatment for tuberculosis or sexually transmitted infections. Individuals at higher risk for HIV acquisition should be screened at least once per year, with consideration of more frequent testing, for example, every 3 months or 6 months, depending on an individual's sexual behaviors, drug use practices, and local epidemiology. All individuals with signs or symptoms consistent with HIV infection or possible HIV-related illness, also known as opportunistic infections, should also be tested. And last, all pregnant people should be tested at each pregnancy. Lack of access to routine healthcare exacerbates inequities in HIV screening, prevention, and treatment, threatening to erode progress toward ending the HIV epidemic in the United States. When we look at the percentage of individuals who know their HIV status by age, we see on the far side, individuals age 13 to 24, only 56% of individuals living with HIV have been formally diagnosed. The rate increases as you increase in age. With those who are aged 45 and older, 90% or higher are aware of their HIV status. Public health strategies have shifted to a status neutral approach in which an HIV test spurs action regardless of the result. This helps to normalize HIV testing and prevent stigmatization. In addition, it helps to address the HIV needs of the entire population regardless of one's HIV status. For example, an individual completes an HIV test and is negative. They can then be linked to HIV pre-exposure prophylaxis services, continue to engage in care, and ultimately reduce the risk of acquiring HIV. In contrast, if an individual has a reactive HIV test, they can be linked to treatment, hopefully retained in care, and ultimately achieve virologic suppression. The key goal of retaining folks in care is achieving sustained virologic suppression. This is the foundational principle underlying U equals U, or undetectable equals untransmittable, which we'll talk about in a later slide. Today's diagnostic tests reduce the time to diagnosis and treatment of early HIV infection by decreasing the window period. Following an exposure that leads to HIV infection, the time during which no diagnostic test can detect HIV is called the eclipse period. In contrast, the window period is the time between a potential HIV exposure and an accurate test result. The gold standard is a fourth generation P24 antigen antibody test. However, it does require that an individual is brought back for a follow-up appointment or receives a call to discuss the results within 7 days. Each HIV test has its own testing window. Rapid HIV tests are great because there are several advantages. You can get the results within minutes. It may increase access to prevention or intervention, linkage to care, for example, and it requires minimal to no equipment or skill. However, rapid HIV tests can miss recent or acute infection. It's important that if the test is reactive, an individual requires a confirmatory test. And if acute infection is suspected, for example, an individual reports symptoms that are consistent with acute HIV or recent high-risk exposure, a viral load should be checked as well, due to the delay with a antibody antigen test turning reactive. Also, window periods are going to vary by HIV test type. For example, a nucleic acid test, or a NAT, is going to turn positive first and has the shortest window period. In contrast, a rapid antigen antibody test, for example, may take up to 3 months to turn reactive. Now moving to cultural humility. Cultural humility may reduce the effects of minority stress by fostering a positive intercultural relationship and engagement between the provider and patient. It leads to greater self-awareness, reduced implicit biases, and increased sensitivity to the power dynamics in cross-cultural interactions. Culture encompasses any dimension of diversity, including class, gender, sexual orientation, and ability, and is not limited to race and ethnicity. Cultural competency and cultural humility are not the same thing, although there is some overlap. Cultural competency is based on the premise that the more one knows about other cultures, the greater their competence in practice. Cultural humility, on the other hand, involves entering a relationship with the intent to honor the other person's beliefs, customs, values, and entails ongoing self-reflection with a willingness to learn from others. More emphasis on interpersonal sensitivity and appreciation of individuality rather than stereotyping or knowledge, finite knowledge of others' cultures. Cultural humility requires clinicians to not only acknowledge, but also address their own biases. Both involve working collaboratively, working with difference, and addressing inequalities. In addition, there are the 5 R's of cultural humility, 5 different domains that consist of reflection, the aim of which is to approach every encounter with humility and understanding that there is always something to learn from everyone. Respect, the aim of which is to treat each person with the utmost respect and strive to preserve dignity and respect. Regard, the aim of which is to hold every person in their highest regard while being aware of and not allowing unconscious biases to interfere in any interactions. Relevance, the aim of which is to expect cultural humility to be relevant and apply this practice to every encounter. And resilience, the aim of which is to embody the practice of cultural humility to enhance personal resilience and global compassion. Although each patient is unique, there are several key practices to consider in an effort to build trust with patients. The first is to examine your own personal biases. Be aware of microaggressions you may be causing. Don't assume a patient's race, ethnicity, gender, or sexual identity, cultural references, or really anything else. And practice cultural humility. Learn about the patient's family, support system, and responsibilities. Ask open-ended questions to give the patient an opportunity to share what their concerns are. Support resilience. Rather than labeling someone as at risk, see promise of future good health and well-being, anchored in resilience and supported by the care team. And address fears and concerns about medications, engaging with the healthcare system, etc. The SIEO model is one model that may be helpful when thinking about gender and sexual diversity among your patient population. S stands for sex assigned at birth, often male, female, intersex, or difference of sex development. Gender identity, being cisgender, transgender, non-binary, for example. Gender expression, feminine, masculine, androgynous. And sexual orientation, for example, straight, gay, lesbian, pan-bisexual, or queer. When initiating a discussion about sexual health, one framework is the 5 Ps. This includes initiating a discussion and discussing partners. With whom are you having sex? Practices. What are your sexual practices with your other partner? Past history of sexually transmitted infections or use of PEP. Protection against STIs. For example, are you using barrier protection, condoms, and plans for pregnancy or parenthood? Now let's discuss pre-exposure prophylaxis. Pre-exposure prophylaxis, or PrEP, refers to the use of antiretroviral medication by people without HIV to prevent HIV acquisition. The CDC recommends that all sexually active adults and adolescents be informed about PrEP. When taken as prescribed, PrEP reduces the risk of HIV acquisition from sex by 99%, and in the setting of injection drug use by at least 74%. The CDC also outlines clinical eligibility criteria for PrEP. For example, an individual must have a documented negative HIV antigen antibody test within a week before prescribing. The individual should report no signs or symptoms of acute HIV infection, and those questions should be explicitly asked. The individual should have no contraindicating medications, should have a presumed normal renal function, weigh at least 35 kilograms, and importantly, PrEP may be given to individuals who are pregnant, using gender-affirming hormone therapy, using injection drugs, or have hepatitis B. These are not contraindications to PrEP. When should PrEP be considered? So the CDC provides some guidance here as well. So an individual who has been recently diagnosed with an STI or requested STI testing in the past 6 months, an individual who reports inconsistent or infrequent condom use, recent use of non-occupational post-exposure prophylaxis, or multiple uses of post-exposure prophylaxis, an individual who's requesting HIV testing, has a partner who's living with HIV, reports being non-monogamous or concerns that their partner is non-monogamous. If the individual is engaging in sexual activity in an area where there's high HIV prevalence or within a sexual network that has high HIV prevalence, is engaged in transactional sex, uses drugs or alcohol, particularly in relation to sexual activity, reports use of injection drugs, a personal history of incarceration, or a partner who's been recently incarcerated. And most importantly, anyone who asks for it. There are 3 current FDA-approved PrEP medications in the United States. The first is emtricitabine TDF. It was approved in 2012. It's a fixed-dose oral combination pill that can be taken once a day or on demand, known as a 2-in-1 approach. The most common adverse effects reported are things like headache, nausea, and abdominal pain that typically resolve with continued use. And importantly, this is the only PrEP medication that is approved for HIV prevention, regardless of your potential transmission risk: sexual transmission, injection drug use, heterosexual, same-sex, regardless. It is contraindicated in individuals who have compromised renal function with a clearance of less than 60. The second medication that was approved for PrEP in the United States was emtricitabine TAF in 2019. It is also a fixed-dose combination pill taken once a day. It is not approved to be taken on demand or 2-in-1. The most common adverse effect reported is a small amount of weight gain, and it is approved only in the setting of sexual transmission between individuals assigned male sex at birth. It is contraindicated in individuals who have a creatinine clearance of less than 30. It's not currently approved in individuals who are pregnant or in the setting of injection drug use. Most recent PrEP medication approved in 2021 was injectable cabotegravir. It is given as an injection, and following the loading doses, it's given every 2 months. The most common reported adverse effect is pain at the injection site, which typically lessens with subsequent doses. It's approved for any individual who's at risk for HIV acquisition in the setting of sex, heterosexual, same-sex, it doesn't matter. It is not currently approved to be used on demand in individuals who are pregnant or in the setting of injection drug use. And then importantly, there's a new medication that is currently being studied, and the results look very promising, called lenacapavir. Lenacapavir is a medication that is also given by injection, but it's given every 6 months. And studies thus far have shown that it is highly effective at preventing HIV acquisition and very well tolerated. It's not currently FDA approved, but it's expected that that is coming down the pipeline. Same-day PrEP initiation is one potential strategy for expanding low-barrier PrEP services. To use same-day PrEP initiation, a practice must be able to conduct point-of-care HIV testing. Oral testing is not recommended. Rather, a blood test for antigen antibody testing is preferred, as well as a pregnancy test if the individual has pregnancy potential. In addition, blood should be collected for creatinine measurement, as well as 4th-generation HIV testing, which will be sent to the lab. Follow-up needs to be able to be arranged quickly if the labs indicate HIV infection or renal dysfunction. And you need to be able to provide scheduled follow-up care and be able to contact patients if the labs indicate that PrEP needs to be discontinued. The CDC recommends certain testing for individuals who are starting PrEP at baseline, as well as safety monitoring labs. At each appointment, individuals should have HIV screening by blood test performed at baseline and then every 3 months. In addition, everyone should have a measured creatinine clearance to confirm that the oral medication is safe for them to take. All individuals at baseline should have sexually transmitted infection testing, including gonorrhea, chlamydia, syphilis. Hepatitis B serologies should be checked. Hepatitis C can also be checked. And again, pregnancy testing for individuals of pregnancy potential. The frequency of STI testing, of creatinine clearance testing, is going to vary depending on an individual's sexual practices or injection practices. Testing for individuals who receive injectable cabotegravir for PrEP differs slightly. Because there's no contraindication for low renal function, estimating creatinine clearance is not necessary, for example. However, all individuals should have both HIV antigen antibody testing, but also critically important HIV viral load checks at each visit. This is because for individuals who are taking cabotegravir, often there is a delay in when the antibody antigen test turns reactive, but the viral load will be reactive earlier. In addition, routine sexually transmitted infection testing for syphilis, gonorrhea, and chlamydia, again, at baseline, and then depending on an individual's sexual practices. In terms of comparing prescribing oral PrEP and injectable PrEP, all individuals should have an HIV status confirmed within a week of prescribing. The interval will differ, with individuals taking oral PrEP receiving a 3-month supply, individuals taking injectable cabotegravir receiving injections every 2 months. In addition, screening for HIV with an antigen antibody test and or HIV viral load should be done to align with prescribing every 3 months or 2 months. You should also assess for signs and symptoms of acute HIV at each visit, assess for adherence at each visit, and then the frequency of STI testing, again, will vary depending on an individual's sexual practices. So who's using PrEP in the United States? If we look at rates of PrEP use by race ethnicity in the United States in 2023, we see that although Black individuals account for 39% of new HIV diagnoses, they account for only 14% of PrEP users. A disparity is also seen for individuals who are Hispanic, representing 31% of new HIV diagnoses, but only 18% of PrEP users. When we look at Pennsylvania specifically in 2023, we see similar trends, with Black individuals representing 46% of new HIV diagnoses, but only 16% of PrEP users. Smaller disparity is seen for Hispanic individuals, who represent 19% of new HIV diagnoses and 8% of PrEP users. Another metric that is used to evaluate PrEP equity is looking at something called the PrEP to need ratio, where the numerator is the number of individuals prescribed PrEP within a given group in a given year, the denominator representing the number of new HIV infections in that same group in the preceding year, with higher numbers representing more PrEP users. And what we can see on the y-axis is the PrEP to need ratio, along the x-axis is the year since PrEP was first approved. And in the light blue line, which represents non-Hispanic white individuals in the US, we can see that the PrEP to need ratio steadily increased over the past decade, much, much less so for individuals who are Black or Hispanic. There are multiple barriers to PrEP: individual level, provider level, and societal structural level. Individual level barriers that have been identified include low rates of awareness of PrEP, inaccurate HIV risk perception, medical mistrust, concerns about confidentiality, and competing priorities. From a provider's end, knowledge gap is also a concern. In addition, lack of comfort about discussing sexual practices and HIV prevention, competing priorities and time constraints, concerns about billing and reimbursement are also barriers. And then at the society level, attitudes about PrEP, phobias, sexism, racism, HIV-related stigma, lack of healthcare access, and cost are just a few of the barriers that have been identified. There are several ways of helping patients pay for PrEP. The first is that PrEP has a USPSTF grade A recommendation, which means that most commercial insurance programs and Medicaid programs will cover PrEP without cost sharing for the patient. Prior authorization may be required though. Some states also have their own PrEP assistance programs. Some will cover the medication alone, others will cover the PrEP-related visit and lab costs, some will cover both. For example, locally in Philadelphia, Philly Keep on Loving is one program that is used to expand low barrier PrEP services. Assistance programs are also available, although they do vary by insurance status. and some resources are included here. Another strategy for preventing HIV acquisition is non-occupational post-exposure prophylaxis, or NPEP, for HIV. Substantial risk for HIV acquisition depends on both the exposure, the type of fluid, for example, and when it occurred. So if an individual was exposed during vaginal intercourse to semen and the partner is living with HIV and has an elevated viral load, for example, that may be an indication for the individual to receive non-occupational post-exposure prophylaxis if the exposure happened within the past 72 hours. For non-occupational post-exposure prophylaxis, a baseline assessment is required. An individual should have a rapid HIV test at baseline, a pregnancy test if there's pregnancy potential, evaluation of renal function, liver function, STI testing, hepatitis B serologies, and hepatitis C screening. In addition, there are 2 first-line regimens for post-exposure prophylaxis. It's a 28-day regimen and often consists of TDF, emtricitabine, plus either valtegravir, given twice a day, or dolutegravir, given once a day. An alternative regimen is TDF plus emtricitabine using a protease inhibitor, but that is considered the second-line regimen. Now let's discuss initiating treatment for HIV. HIV treatment initiation guidelines vary in terms of immediate starts or 7-day starts, for example. When initiating antiretroviral treatment before you have the drug resistance testing or the results of other baseline examinations, one of 2 regimens is recommended as a first-line treatment. The first is bictegravir, tenofovir alafenamide, emtricitabine, which is a fixed-dose, single-tablet combination pill. The other is dolutegravir plus either TAF or TDF, plus either emtricitabine or lamivudine. For individuals who have a history of taking injectable cabotegravir for PrEP, it's recommended to use a different class of medications that's not integrase-based. In this case, a protease inhibitor regimen with boosted darunavir plus TAF or TDF plus emtricitabine or lamivudine, pending the results of the genotype resistance testing. Baseline examination includes the labs that are outlined here. Important things to note: you want a baseline CD4 count and viral load. You want to check the complete blood count and comprehensive metabolic panel, looking at liver and kidney health, for example, hepatitis A, B, and C serologies, serum lipids, and importantly, every individual should have a baseline genotype drug resistance test and be screened for sexually transmitted infections. Treatment with the pre-specified regimens on the prior slide can begin before results are obtained. The goals of treatment include achieving sustained virologic suppression, restoring and preserving immunologic function, reducing HIV-associated morbidity and prolong the duration and quality of life, prevent HIV transmission, and this leads into undetectable equals untransmittable. There are 3 landmark studies that have shown for individuals who engage in both sexual and male-to-male sexual contact that if individuals have a viral load of less than 200 copies per milliliter, they are unable to transmit HIV during condomless sex. That's the underlying principle behind undetectable equals untransmittable, or U equals U. In addition, immediate ART initiation on the day of diagnosis has been shown to increase antiretroviral uptake, increase engagement in HIV medical care, and accelerate time to achieving virologic suppression. This is important because some people do not engage in care between initial diagnosis and the time antiretroviral therapy is prescribed. In conclusion, we've covered a lot of material, but here are some of the key takeaway points. PrEP reduces the risk of HIV acquisition via sexual transmission by 99% when taken as prescribed. An HIV status neutral care continuum addresses HIV needs of the entire population, regardless of HIV status. PrEP is indicated to prevent HIV via sexual transmission in adolescents and adults and should be considered for all sexually active adolescents and adults. The only contraindications to PrEP initiation are HIV infection or a weight less than 35 kilograms. PrEP is underprescribed to people who are Black and Hispanic in the United States. Cultural humility involves ongoing self-reflection and can foster positive intercultural relationships and engagement. Everyone with HIV should be treated, regardless of CD4 count or viral load. Some antiretroviral regimens may be used before baseline testing results are available. The single tablet regimen of bictegravir, tenofovir, alafenamide, and emtricitabine is appropriate for rapid start for people with no previous exposure to injectable cabotegravir for PrEP. And now back to you, Tabitha.
Thank you, Dr. Watson. And now we'll revisit those questions that we saw at the beginning of the program. Question 1. Which of the following statements best describes the status neutral care continuum? Please take time to answer now. Here is how you answered previously. And here is how you answered now. And the answer is D. It addresses HIV needs of an entire population, regardless of HIV status. The status neutral care continuum emphasizes continued engagement in HIV care, prevention, or treatment for all people, depending on their HIV test result. People who receive a negative test result should learn about options for HIV prevention, and people who receive a positive test result should receive treatment for HIV. All people should be retained in care to either prevent or treat HIV. Question 2. Which of the following features distinguishes cultural humility from cultural competency? Please answer now. And here's how this was answered previously. And here are the answers now. And the correct answer is A, critical self-reflection. Critical self-reflection is a feature of cultural humility, but not of cultural competency. Generally, cultural humility involves ongoing self-examination and learning. Question 3. Which of the following is a contraindication to PrEP? Please provide your answer. Here's how you answered previously. And here's how you answered now. And the correct answer is D, reactive HIV test. A reactive HIV test is a contraindication to PrEP because while the medications in PrEP can prevent HIV infection, they do not form a complete regimen to treat HIV infection. Another contraindication is weight less than 35 kilograms. Hepatitis B infection, pregnancy, and use of injection drugs or gender-affirming hormones are not contraindications to PrEP. And question 4, which regimen can be offered to people with no previous use of cabotegravir PrEP who are newly diagnosed HIV before results of baseline testing are available? Please go ahead and provide your answer. And this is how you responded in the pretest. And these are your responses now. And the correct answer is A, bictegravir, TAF, FTC. The U.S. Department of Health and Human Services recommends certain regimens for people who initiate ART before the results of baseline testing are available. For people who have not been previously exposed to cabotegravir PrEP, options include the single tablet regimen of bictegravir, TAF, FTC, or the combination of dolutegravir plus TAF or TDF plus 3TC or FTC. Thank you for joining us today. We would also like to thank Dr. Watson.
Thank you for having me.
Please remember to complete the evaluation shown on the console to claim your education credit. For more information, contact us at info@dkbmed.com. Thank you and see you next time.